have Dr. Karbanda, Professor Karbanda, another stalwart of our program. And thank you all for Dr. Karbanda and Rajiv for putting and Derek for putting this, taking all the trouble to bring this second program on dental um, uh, ethics, and in the context of the COVID pandemic that we are facing. I, as we always do, I want you to know this is the 37th uh, webinar, or which we call now a panel discussion conference. It's been very important, very informative, and as you know, we have been going through covering a number of disciplines. And very importantly, I think our dental discipline is also going to do this. We have been able to come out with expert guidelines from these conferences for the various disciplines. And we've had the pharmacy come out, which is now accepted by the International Pharmacy Association. Similarly, the nursing have come out, and I'm sure our dental will also be following this after this conference takes place. Now, as I usually do, I will ask the co-chair, Professor Mary Matthew, to also welcome all of you and say her part.
Thank you, Dr. Russell, and welcome once again. This is our 37th webinar, as Dr. Russell said. And this is part of our series on specialized profession webinars for the COVID-19 pandemic. And this is for the dentistry profession, and this is our second webinar for the dental profession. Now, many of you know that as the head of the Indian program, many of you know, at least those who are in India know that the government of India has already released guidelines for the dentist, for the dental profession in May 2020. And I'm sure most of you would have gone through it. So in our initial webinar, we talked about the difficulties that the dental profession was facing, and we're taking this webinar is one step further. What do we do now because the pandemic has not actually subsided? We were hoping when we first when we did our first webinar that everything would come down and this pandemic would hopefully disappear, but we are seeing that it's reducing, yes, but still it's causing a lot of difficulties in the profession. It's not only for dental, but for practically every healthcare profession. So we have eminent speakers, and of course, Professor Karmanda, Professor Chad, and Professor Peter Mose are not, they're not new to this platform, but we do have a new panelist who will take this discussion forward. So I want to thank Dr. Rajiv Aluwale, who's put in a lot of effort along with Dr. Derek to bring this program together. I want all of you to know that we also have students on this webinar, and because of the sheer numbers we have right now, as of now, 224 participants. We may not be able to.
मैं भी वेबिनार में हूं, मैं बाद में बात कर सकता हूं इंटरनेशनल वेबिनार में.
Could Dr. Derek, you'll have to mute. Yeah. Thank you. And we may not be able to take all the questions. So what is the most common, or what is the most relevant questions are the ones that we are going to ask. And if there is time at the end, of course, we'll answer the questions. And please feel free to put your questions in the chat box as always. If you're from another country other than India, please put your which is your country, and are you a student or a faculty? So that would help us to prioritize the questions. So thank you very much, and welcome to our 37th webinar, which is going to focus on the dental profession. Thank you.
Thank you, Dr. Mary, Professor Mary. So now we have Derek, Colonel Derek, Professor Derek D'Souza, who's going to be, along with Rajiv, going to be the moderators for this program. So let me introduce. I'm very delighted to introduce Professor Peter Mosey, who is the Dean at the International School of Dentistry at the University of Dundee. But Professor Peter is also we last year he became part of our department of education from the dental faculty and has come on this program a couple of times. And I think, Peter, you're also in the journal Bioethical Inquiry. I think you're joined the editorial board. So a big welcome to you from our department, from particularly from the dental faculty. We then have also, I'm proud and very happy, the honor to introduce Dr. Chad Gihani, who was the president of the American Dental Association, and he was there before, and he's also been part of our program, joined um, the Department of Education, and has given a couple of lectures at our various meetings of the Department of Education. So welcome to you, Chad, um, today, and we look forward to your contribution. And Dr. Karbanda, of course, Professor Karbanda, he's part of our of the national program, one of the very senior professors of apparently a chair, national chair at the ICMR in India. But I'm going to introduce to you these three um, very distinguished speakers and academicians who are going to present us the model as for all of those of you who haven't followed what we're doing in 21. We now have we start with two or three sharp presentations, and then that sets the scene, and we then go on to the panel discussion conference, as it were. So I'm delighted that Dr. Karvanda is going to talk to us on dental education and the way forward. And Professor Peter Mosey will be talking on clinical dentistry. Will it be the same again? And Dr. Chad Jihani is going to present to us economic impact of COVID in general dental practice. And of course, we have, after the second part of this webinar conference, will be the panel discussion from the very distinguished panelists we have from different regions of the world. And so we have Dr. Lakshman, Dr. Pradeep, Dr. Nilanta Ratnaike, and Dr. Shalini. I think all of you have been in the last, you're all panelists in the last webinar too. So big welcome to all of you. And once again, thank you all for joining. Derek, is there any housekeeping rules you want to tell everyone before we invite our very distinguished speakers to come on the floor to take on the presentations? I think each of you will be speaking for around roughly, no, I just said that roughly I think we are expecting that we'll all speak for around 8 minutes each presentation. That should be fine. Okay.
Yes, Dr. Russell, good evening, and thank you for that introduction to the entire program and for setting the stage for us. It's really wonderful to have this panel of luminaries from all around the world, and it's wonderful to have such a large number. We're almost touching 200 as of now. So welcome to all
281.
the students, faculty,
281.
everyone who all are there. And I have already put in the YouTube live streaming of this proceedings. So please feel free to share that with your friends and on WhatsApp. So even in case someone is unable to join via Zoom, they can just log in and watch the proceedings there. We'll be monitoring that as well. Again, all the participants who are here, you may not get a chance to ask your questions directly because I know we'll have a lack of time, but you can put in your questions or your comments in the chat box, and I'll request our distinguished panel, who is also able to see that, you can feel free to answer the questions or put in your comments there as well, so that we can have the questions answered even while one of the other panelists are speaking. So in case you feel that you have uh, some comment to make, our participants, put that into the chat box. If you would like to address it to a specific panelist or speaker, you can do that as well so that they can respond when they have the time. Rest, we will try and accommodate maximum number of questions and comments. And I now invite Dr. Raju Aluwalia to first release the
Oh yes, we
ethoscope.
got that.
And
We got that.
we must acknowledge the fact that as part of the National Bioethics Program team and Santosh University, they have put together this newsletter of bioethics, which is going to be a medium by where we can help to transfer the information very quickly, and we hope it's going to become active and grow in the months and years ahead. So I request Dr. Rajiv Aliwalia to put it up to Dr. Russell D'Souza for its release. And following that, you can introduce our very distinguished panel of three speakers who will set the stage, and we'll go ahead. Dr. Rajiv.
Yeah. Rajiv, let me introduce. We have a very active bioethics, dental bioethics program, a large program. And it's a great pleasure and a honor and very auspicious that today at this conference we are going to release the um, newsletter magazine, as it were, called Ethoscope. This is a newsletter of dental bioethics from our program. And I want to congratulate Dr. Rajiv Alwalia and Dr. Kharbanda, who have taken a role in bringing this together. And we have got a team of the national, who are the committee of Dr. Rajiv Alwalia. So I've gone through it, and it is indeed very interesting. A lot of students have put a lot of effort into this, and I want to congratulate all of you at Santosh, and indeed for the whole national program for bringing this out. It is a great pleasure that I'd ask Rajiv to please hold that up so that we can release it, and then you can say a few words as the editor of the um, Ethoscope.
Thank you so much, Dr. Russell. And I'll immediately start with the instructions what Dr. Russell has given me. So this is the covered, COVID has taught us many things, including releasing of manuals, online. So I would have wished Dr. Russell to manually be opening it. This is my university logo. This is the logo of the National Dental
National
Bioethics
Dental
Unit.
Bioethics.
So here I go. And this is the ethoscope, and lot of effort has gone into it, and people have worked on it. We've been working on the unit was started in 2016 when Dr. Russell, Dr. Mary Matthew, and Dr. Derek had come to our university. And what should I say? It's the charisma of Dr. Russell, the grace of Dr. Mary, and the friendly attitude of Dr. Derek, and of course mentorship of Dr. Kharbanda. And I thought that the best, bioethics is something which has to go to people. People don't come to it. So this was the best way, and the editorial team, which compromises mainly of our students at the university, has, they have gone deep, percolated into the districts and different cities of the country, and uh, you know, this is the foreword from Dr. Russell, and all our bioethic executive committee members, advisors, Dr. Karbanda, and all the programs that had been done at the local level, at the university level, at the national level, the bioethicon which we had in Chennai, a huge conference, at AIMS conference. And I would like to draw your attention onto this page, which is totally a student's endeavor. And they've gone into, we've divided the country into 5 zones. And from each zone, there are many students who are writing to us, who want to be part of it, and who feel, they're the generation ahead. They want to live in a very dynamic and bioethical society. So kudos to the young people, who've been working on this. And this is the editorial team. And thank you, Dr. Russell, for your guidance. So,
Rajiv, can I suggest that you put a PDF copy into the chat box? So
okay.
I think everyone will get a copy right away, and it will be there on record as well. And of course, I think we'll be sending it out to everyone on email later. But right away, I think we can put it as a sign that it has been released into the chat box. If that is possible, or
Yes,
one
yes,
of your students can
yes,
do it.
yes, yes, sir. We'll just do
It
it.
need not be right away. You can take your time. And
Yes, yes, sir. We'll be doing it. Our team will just.
yeah, yeah.
So now,
Thank you. Please
coming on,
yeah.
coming on to the present webinar. So I'll take a recap. I'll just take a minute to tune members. Our first international webinar on dental bioethics was on May 24th. That was really in the deep of COVID, And as Dr. Russell has suggested, we had summarized that webinar, and the summary was the steps which were suggested, or the take-home messages were: postponing non-emergency procedures, teleconsultation is the need, running private clinics with 50% capacity, documenting travel history of the patient, social distancing and mandating, minimizing aerosol production, rubber dams were very importantly suggested, pre-operative screenings and mouthwashes, avoid overuse of antibiotics, and the need for cross-national guidelines. This was kind of the summary of our first webinar, which was held on May 24th. Now, subsequent to that, more people have united with us, have got in touch with us. Those, I think we had over around 500, 600 participants that time. And many questions and all have been coming to us. And that gave the need or urgency to have the second webinar with our experts. So today we have 3 presentations, and what we could broadly see 3 parameters where guidance is required. First is on clinical dentistry, and definitely there are doubts whether it is going to be the same again. Who better than Dr. Peter Mosey to talk about, and if I could use the word, open the innings of the webinar with Dr. Peter Mosey, who will guide us on that. He's a professor of craniofacial development, associate dean internationalization, School of Dentistry, University of Dundee. He would be talking on clinical dentistry. Will it be the same again? Next presenter would be Professor Dr. O.P. Karbanda. I proudly associate with him as my mentor. Currently, he is Dr. C.G. Pandit National Chair, Indian Council of Medical Research, Department of Plastic Surgery, All India Institute of Medical Sciences, New Delhi. And we thought he's the best person, I would say, currently, who could guide or who would know the situation on dental education and the way forward. And of course, the third topic, which actually is the most important topic, is economic impact of COVID on general dental practice. Of course, there's been an economic impact on all type of professions and businesses. And so what is the economic impact on our dental profession? So we are very, very honored to have Dr. Chad Gihani again on our web. And he's the past president of the American Dental Association with his vast experience and executive director, Queens County Dental Society. He's the adjunct professor, New York University. He is going to tell us about the economic impact. And broadly, we have many queries, or of course, they will come on the chat also, which are on clinical issues, which are on education. Other than there are a lot of queries on vaccine also. So let's set the ball rolling, and I would invite Dr. Peter Mosey to kindly start his presentation on, I'm also very keen to know whether clinical dentistry and is it going to be the same again. Over to you, Dr. Peter.
Thank you very much, Rajiv, and welcome everyone. And many thanks again just to the organizers. I'm delighted to be part of a really very well established and prestigious bioethics program. I'll get into the meat of this right away because it's a very interesting and crucial question. Will clinical dentistry ever be the same again? And I think most people will know the answer, but I'm going to elaborate. I don't think it ever will be the same again because we will have to learn to live with COVID. And I think this should be a wake-up call for the dental profession to adapt to this new reality. But even if we are highly successful in eradicating COVID, the risk of other or new airborne infections will continue. So to ensure that dental practice remains safe, we'll be adopting precautions to ensure that airborne infection is not sourced in dental practice. We obviously did this very successfully a couple of decades ago when we were confronted with bloodborne infections and the likes of HIV and hepatitis B. So we took precautions to ensure that our patients were safe and our fellow professionals were safe. So in the future, we will be adopting the PPE systems that we've all got so familiar with now in dental practice. We'll adopt those as part of our universal precautions against cross-infection, and we'll have all that range of infection procedures, cross-infection procedures that Rajiv mentioned within dental practice. The sanitation, the hygiene, the air exchange, the high volume aspiration, all of that. Plus, we'll probably still continue for quite a while on making sure that our testing systems are in place for both staff and for patients. So that's number one. Number two, I think we've got to reduce the number of procedures that involve AGPs. And in the future, we can do this in a number of ways immediately, and some will take a little bit longer. But for example, with immediate effect, we can use different hard tissue cutting techniques for enamel and dentin. We could use, for example, electric drills, which some institutions are now introducing, as opposed to the rotor diamond drills and other drills that we use. We can actually, in restorative dentistry, use rubber dam, use mouthwashes, reduce the viral load. We can also, in pediatric dentistry, use new techniques such as stainless steel crowns to seal in caries using, for example, the Hall technique. We can use more minimally invasive dentistry. And in my own specialty, I'm a clinical orthodontist, we can be AGP free. There are many ways where, for example, banding and bonding and debonding techniques do not need to use aerosol generating procedures. And I think for example, in orthodontics as well, can use aligners and other techniques. So we've got to adapt our clinical practice. Number 3 in my list of changes that will be sustained well beyond the pandemic is the use of teledentistry. I think prior to the pandemic, dental professional care was way behind the curve with the use of teledentistry. And there's tremendous potential for remote consultation, beginning with triage, to assessment, to review. Pre and post-operative consultations could be carried out remotely, and longitudinal follow-ups. So all of that has been now up and running for quite a while, and enough time to gauge feedback. And I see the results of surveys that have consulted with patients, and there's a high level of patient satisfaction. So they can be used to good effect. But the other aspect of teledentistry is the fact that it is an extremely useful and versatile educational tool. And for example, here in Dundee, we're now beginning to use this for unique access for students to multidisciplinary clinics that they probably would not have had an opportunity to do in the past. So these are questions of what I would describe as building back better, making sure that our techniques in the future take the best of what we've learned over the pandemic period. My last point on this is related to prevention and primary prevention. This is more of a immediate to medium to long-term solution to many of the current challenges in dentistry, including the tremendous global expenditure. And I'm sure Chad later will be telling us more about this. But for far too long, dentistry has been an interventionist profession, and we need to switch from intervention to much more focus on prevention. Dental diseases have a very significant environmental component and are highly preventable. So it could be looked at as one of the failures of dentistry is that we have been much more focused on the cure than the prevention. And just to reflect back 2 months ago, or less than 2 months ago, in January 21, to the World Health Organization Executive Board, EB 148, they have set the scene for this. And Dr. Tedros described this as a landmark moment for dentistry, where he said that our focus on common risk factors and social determinants should enable oral health to be part of the global health and well-being drive for the future. And this is where dentistry can make a very significant impact and make sure that in the future our practices are much more orientated towards prevention and reducing, therefore, the need for aerosol generating procedures through the preventive program. I'm happy to stop there in the interests of time, but there's many aspects of this that I'm very happy to elaborate on in the follow-up chat. Thank you.
Thank you, sir, for that very succinct description, I think, of the current situation and for showing us the way forward. I think you're absolutely right. It's good that we had a rethink because a lot of things we took for granted, and probably that led us to a sort of mental stagnation, may I say. Technologically, we were improving on so many aspects, but like you correctly said, teledentistry was something we never really explored. It was just left there in terms of, yes, it is a possibility. But today you'll agree with me that we can really use it as a force multiplier. Today technology has improved, connectivity, communication has improved, and this has forced us in a way to rethink the way we practice basic dentistry, prioritize the patients, especially in the rural areas, people who can't really have a direct connection to a specialist. It's absolutely new and wonderful way that we can reach out. So thank you for highlighting that, and I'm sure we can work on that on the future. Participants and students, please feel free to address any questions you have to Dr. Peter Mozzi, and I'm sure that he'll answer them in the chat box for us. Uh, with that, we move ahead to our next lead presenter for the evening, Professor Kharbanda. I know the students already have a lot of worry. We can see the questions already coming in the chat box. They're wondering about their basic curriculum. Is that going to be addressed? What about their clinical concerns? What about the whole practice of the way the dental education is going to move ahead? So, sir, the floor is yours. You can share your thoughts for us.
Yeah, thank you. I'm delighted to be part of this very special program, and it is indeed an honor. Thank you, everyone. I like to share my screen if I am allowed to. So please
Yes.
permit me, the
You
administrator.
can, sir.
Yeah.
You can, your co-host.
You're a co-host, so you can do it.
Yeah. So now the topic.
Not yet visible, sir. Just
not visible.
click on
I have shared.
not yet.
I've shared. So.
Yes, now.
It is visible now? Yeah.
Just go to full screen, please.
Yeah, going. Is that
yes.
all?
Yes, perfect, sir. Please go ahead.
First of all, I would say that since the time Rajiv discussed with me to talk about this dental education, the way forward, actually my mind has been really been disturbed quite a lot, like if I am true to say this, because I found that there are so many issues which need to be resolved, but before I go to education, actually, what we need to say is that dental profession, will it be the same? And then I started looking back into things that when I was a student, how was my profession and how it has grown today, or even from the Egyptian times. And I said that it was never the same. It always evolved. And I think so that it is not moving forward. Yeah. It was never the same. So why we are expecting that it will be the same again after pandemic? Obviously, it cannot be the same. It has to evolve. Life has to go on. I just looked in my own book on orthodontics, and I realized that in this book I had put in some pictures of the time when they used to fix the natural teeth with wires as a bridge. You would be surprised that I used this foot engine as a student. I used to drill cavities using this foot engine, and to your surprise and my surprise, I had a patient visiting me after almost more than 3 decades with a silver amalgam restoration from US, and that lady still carried that filling intact. So what was needed? It is not the how you do it, but with what involvement you do it, what principles you take care. And by the time I was in final year, we got to this electric engine. Now these modern dental clinics have a lot, but how these clinics are going to look like after these huge number of people, because the danger is not from those whom we know who are infected. We have a danger from those who are infected and whom we don't know if they are infected, because those who are carriers. If we know they are infected, if they are COVID positive, we do take precautions. If we know that person has AIDS, we do take precautions. If we know he has hepatitis, we do take precautions. But what about those about whom we don't know? And I think there are more people about whom we don't know than we know. So major challenge which we all are facing today is from unknown, fear of unknown. And it is this fear of unknown which makes us depressed, which gives us anxiety. And this anxiety reflects in many ways. And more so, a person who is a carrier comes to us and we cross infect. We just don't not only infect ourselves, our staff, and it is cross. It is going from here to there to here. And the saliva, we know that it comes from, it is a very, very rich source of the COVID-19. And this our manuscript in BDJ, from where I have taken this picture, it has recently come a month ago. I mean, when we started looking at the presence of COVID-19 bacteria in the oral cavity, and in many instances, it was much more predictive than even the RT-PCR. So the point I am trying to make here is that when it is a patient is in your clinic, it is the aerosol containing COVID-19, and not only COVID-19, containing everything else, all other infections. So we should have been prepared for this much before, actually. If you ask me honestly, COVID-19 had made us alert to be responsible, but we should have been responsible and taking all these precautions even before that, because we have not given much importance to aerosol in our dental office. This is a kind of pollution in a dental office, which is coming from aerosols, which we had been doing knowingly or unknowingly, about which I think we were not scared, but now we are scared. And now there are new terms coming like pandemic, where dentist is confused, what he should do, how he should do. He is giving up. That means he has to educate himself even and his staff, not only about dental procedures, but also cross-contamination, which was always a part, but I think COVID has told us how to do it more, how to do it better. Now, earlier we talked about infection control, but now we are talking about aerosol management, which is becoming a major issue. All the clinics needs to be modified for air conditioning. We need a HEPA filter, we need air purification, and we need aerosol with the extra oral sections to be taken away. So this is something which is going to increase the total cost. And I know Dr. Gehani would be talking about the impact of this modernization of dental clinic or upgradation of dental clinic. The cost, who is going to bear the cost? The patient. Eventually, it is the patient. And if patient has to bear extra cost, this raises $1 million question, which Dr. Peter Mose has just now raised, that what happened in the assembly, WHO, where they have considered now for the first time oral health prevention as a major contributor to non-communicable diseases, as a major thing. So our dental education is taught as that how to fill a cavity, but we have been never taught how to teach a man to eat properly or rinse properly, or these aspect of prevention, or what is the nature of dental material or dental tissues to resist dental caries. We don't talk about it. We only talk about procedures, modern things, and you have more gadgets, more better dentists you are. And if you start teaching, sometimes even when my orthodontic patients, I start teaching them brushing and making plaque free, they think, oh, you're an orthodontist or you're a hygienist. Oh, but that is my job. I have to keep your mouth clean. If your mouth is not clean, obviously, I cannot do orthodontic. So I think the emphasis on prevention has to come major, and that would also mean that you are going to reduce the economic burden of dental treatment in the country. I understand that in USA, a major chunk of health budget goes for dental. So I think we have to consider that. Other aspect which I think which is very important now is that dental students are in a unique situation, because they are different. And when I going through the literature, I found so many issues coming up with dental education. Dental schools will be able to admit new students, and even if they admit, are their seats getting filled up? For example, I understand in India at least, the takers for dental courses are much less now. And in developed world, the issue would be that if they admit new patients, they won't have enough clinical material or enough dental chairs to compensate for missing training. And the next agenda, which comes very, very, very important here, is that how to conduct the exam, how to assess the technical skills. That is something which needs to be assessed on one-to-one basis. Can they be assessed remotely? Probably yes, but we have to find technology. We need technology for that. I just went through some of the literature, some literature also on the net, and I found that that in Europe the issue is if they have come back, they are not sure. In India, they are still waiting for more policies that how the exam would be conducted, whether they are missing 6 months or 1 year will be compensated or not compensated. Do they have to do it 1 more year? And International Association of Dental Students, they told the Dental Tribune that, well, the most important thing which they find, which is missing, is the clinical training. So the worry about clinical training is the most. You can read, you have virtual lessons, you would have virtual lectures, but dentistry is also about skill. So, for example, in Germany, again, they are saying that it is the clinical procedure. It is the clinical procedure. Virtual platforms are okay, videos are okay, but clinical procedures need to be learned. And for these procedures, perhaps there is no substitute for the clinical training. Now, another term which has come up, which is covidopedagophobia. The COVID has told us some new terminologies. And in this, many teachers, because issue is not just the students. The dental education is not related to students alone. It is equally other aspect of dental education, or major part is the teaching. So how you are going to teach? And many of the traditional teachers are finding it difficult to adopt a new technology. So the teachers need to be also trained to new technology and to this tech-savvy model of teaching, and not having been able to do is now being called phobia, which is resulting in teachers. So I went through a little bit more in literature, but time does not permit me to talk everything in so much detail. I will limit myself to certain points. But here I would like to say that the transition of distance learning has taught us many things. There are some advantages. There are. Everything is not bad, but we have to learn from this and what are the new challenges. I think that is what we need to brief. So if you ask me what is the way forward, this may be my personal view based on what I've been doing, I've been watching, I've been following, that digital and virtual technology is here to stay. In fact, it is a challenge which has given us an opportunity to think differently. It works. Then the virtual dentistry works, particularly in follow-up and initial consult. So the tele-dentistry will come in a big way. And I have personally, many years ago, given an hypothesis, which is that why can't I, sitting in my orthodontic office, control the tooth movement? If I could control a instrument landing on Mars, it should be possible for me to do this sitting if I have a sensor placed somewhere on the tooth, yes, I should be able to do it. So remote control orthodontics, virtual orthodontics, virtual dentistry will come up. But there are issues. There are ethical issues and legal issues. So newer technology, which will develop on imaging and also integrated with telecommunication, should resolve the ethical and the legal issues. However, the human interactions and emotions cannot be substituted. There is no other way you can substitute the human emotions. There is no way you can substitute the touch. So they will have to be compensated with clinical experience. So there is no way we will get out of the clinics. You may be able to draw a virtual cavity, or you may able to draw a cavity on a dummy and share on a net for somebody to evaluate and mark, but that means you need to touch. Even though these things appear simple, but the cost of education and treatment is going to increase. So it is going to increase. So what next? What is the next then? So dental profession is going to evolve. For certain, it is going to evolve. But need for oral health education and prevention, Peter said it in the beginning, needs to be emphasized. Most people in this world won't be able to afford this high-end technology. They may not have. And there is no need to spend that much of money on something which is easily manageable, easily preventable. So I think all institutions, all government policymakers, we as a dental professionals have a duty to lobby to spend as much money on oral health promotion and prevention as on technology. I wish to say here that the challenges are many. This would mean that we need to redefine the curriculum, because if you are talking about knowledge, if you're talking about aptitude, if you're talking about psychomotor skills, so you may have knowledge, you may have psychomotor skills, but these two needs to be combined with gentle touch of hand. And for this, human contact must continue. The issues which will come up now would be redefining the curriculum, redefining the assessment, and making different norms of both the curriculum and assessment and the method of assessment. So this would be a very, very huge topic to discuss. And I think we need a separate, another platform to discuss that. But this issue remains. And I think it is also a time when the policymakers should come up with a clear-cut policies, how they are going to look after those missing hours of clinical and academic training. I think the policies are needed. With this, I think I will I will stop here, and I am happy to answer if there are any discussions, any questions during discussion or in the chat box. Thank you.
Thank you, Professor Karbanda. It's really wonderful to hear from you, and with your vast experience, literally leading the dental profession for so many years. I think you've put it in a very short but effective manner as to how exactly, or what are the thrust areas that we need to look forward as we go forward. And you're absolutely right. It is not really possible to do justice to this entire subject in such a short time, but you've managed to give us some pointers. And I think Dr. Rajiv and the rest of the National Bioethics team can look forward to possibly having maybe a whole day long discussion on this. It may be virtual or on a digital platform, but I think we can pick up each of the points, get the think tanks together, and work ahead for the benefit of the students. Of course, I love your idea of the remote dentistry. As you said, it's a wonderful seed that you have planted in everyone's mind. And of course, it's right that if we can control something that is there on Mars or something that is there on the moon, then definitely we can at least think of it. May not come through in a hurry. I'm sure Dr. Peter Mozzi has already got some ideas in his mind as well, since he is already into research. But it's a wonderful seed of thought, and thank you for that. Professor Chad Gehani. I know not only in the United States, but literally all over the world, the economic aspect has been a major problem for everyone. Professor Karbanda, you can just stop
Yeah,
your
I'm
screen
just trying
share.
to do that. How to do stop sharing? So
Just click again on that, or just a
yeah,
moment.
it happens.
Yeah.
It happens.
Thank you.
Thank
Thank
you.
you, sir. Yeah. So I think Professor Chad has been again at the forefront, not only of the practice of clinical dentistry, but seeing the way that the dental profession has grown, how young dental professionals have progressed, and looking at the economic fallout. I don't think anyone else can take on this role as well as he can. So the floor is yours, sir. Kindly share your thoughts with us. Thank you.
I'm muted.
We can hear you now, sir, please.
Okay, can you hear me?
Yes.
Uh,
Do you have a presentation, or will you just be
no, I
speaking?
don't have a presentation.
Okay,
You
perfect.
all may recall that in March 2020, I made a very painful decision to stop practice of dentistry in United States, except for the urgent and emergency care. That was one of the toughest decisions of my life, to ask the dentist not to serve their patients except for emergency. So the economically, the dentists at that time were totally shocked, surprised, and the economics of the dental practices were down to nowhere. I'm glad to note that as of today, 95% of practices are back up and running. Patient volume in the dental office is about 81%. Most of the dentists, or many of the dentists, have reported that they are seeing more cases of fractures and bruxism, and that can be stress related to the general public. Dentists have increased their fees for them to be economically viable because the patient volume has come down, the cost of the PPE has gone up, and the dentists have to balance their budget. In order for the dentist to balance their budget, many of the dentists have now thought of increasing their fees. Some of the dentists have also started taking some bank loans for them to survive for the time being. So there is a lot of financial strain on many dental offices. Some of the dentists have actually prematurely retired. Dentists who were planning to work for the next 10 years or so, dentists of like my age, they'll come and say, you know what, I really don't want to deal with all this. I'm going to retire. So there are different ways that the dentists have tried to cope up with the current situation. Many dental offices have actually reduced the hours for their team workers, like dental assistants, dental hygienists, and dental technicians working in their offices. They have reduced their total amount of hours that they work in their offices. The owner dentists are pretty much back in work. About 99% of the people who own their offices, they have gone back to their offices. Yet there are dentists who used to work as the employee dentists. Like I may be hiring 3 or 4 employee dentists in my office. They may not be back to the work. So about 70% of the employee dentists are back to work. 30% of the employee dentists currently are not back to work. As we heard from Professor Peter Mosey, about 1/3 of the practicing dentists have performed some sort of tele-dentistry. It could be post-operative consultations. It could be initial consultations. It could be triaging the emergencies and other simple things on the teledentistry. The insurance companies are absolutely recognizing it, including the private patients, absolutely recognize, and they expect to pay when they are consulting their dentist on, on an electronic media. So teledentistry has come to stay. Of course, you cannot perform a root canal on teledentistry way as of today, but teledentistry is one format which has come to stay, and of course, it will perhaps expand much more. At one time, the American dentists generally are very, you could say, they are charitable and they think of the public health, and many of the dentists do engage in public health programs, which is like sort of charity. The public health programs like Medicaid really does not pay as good as the private practice. At the present time, about 10 to 12% of the practicing dentists have somehow decided to disengage their practices from the Medicaid practice. And that causes whole set of different situation for the general public out there, because they cannot find dentists as often as they can. We were pretty strong in reaching out to the press right early on. We made the press understand and the public policy makers understand that dentistry is an essential service. We have always been classified as an essential service. So when it came to giving or getting the vaccinations, we were given a category 1 type of treatment. So we had a preference there. We also reached out to the media that dentistry is very safe. And because of that, most of the patients, the consumer confidence in dentistry is pretty much back. And we are looking for it to come to almost pre-pandemic level. I'm going to stop here in interest of the time. I see that my time here says 8:30 a.m. New York Times. So I'm going to stop here. And if you have any questions, I'm going to leave you with my email, cgehani@gmail.com or gehanec@ada.org. You could ask me any questions at any time. Thank you.
Thank you, Professor Gehani, for giving us that really special look, shall I say, from your experience, from your perspective there in the US and literally all over the world. I think the questions are the same. If you see, the students are coming out with some wonderful questions in the chat box, and we can continue the dialogue there. May I request you to type in your email into the chat box as well, sir, so that the students especially can be in touch with you later. And we're very grateful that you have agreed to continue this dialogue in the days to come, at least from the email. And I'm sure that we'll all work together in looking at a better future. So thank you to those panelists. I think now we have the stage set. They have given us, despite the short period of time that we were able to grant to them, they gave us a little bit of overview of the situation, the way forward, and what are the thrust areas that we need to look at in future. May I now request Dr. Rajiv Ahluwalia to introduce our esteemed panelists for the second part of the discussion today. And once again, I know a lot of you are replying to the queries in the chat box. There are a lot of questions coming in, and some of them are really interesting. So while we continue with the panel discussion, thank you for answering the questions there. And please continue to do the same so that the students can benefit at the same time. Dr. Rajiv, please.
Yeah, it's my proud privilege again to introduce the global leaders who are also our panelists and who are helping us, fight the uh, performance of dentists or dental students, allaying their fears in these COVID times. So we have Dr. Lakshman Samanaike. He's from Hong Kong. He's Professor Emeritus Microbiomics and immediate past Dean of Dentistry, the University of Hong Kong. His specialty, his focus is on COVID vaccine and dentistry. Then we have Dr. Pratip Panthumumbinet from Thailand. He is former Dean, Faculty of Dentistry, Thammasat University, Thailand, Founder Chair, Asian Chief Dental Officers Meeting, ACDOM, Expert Panel on Oral Health, World Health Organization. And his focus is on compensation for lack of skill development and clinical exposure in COVID. Dr. Nilantha Ratnaike is from Sri Lanka. He is consultant in the community dentistry at the Ministry of Health, Sri Lanka. His focus is on online classes and exams, and are they or should they be acceptable the world over? And we have very graceful Dr. Shaili Pradhan from Nepal. She's Chief Consultant, Dental Surgeon, Professor and Head at the Department of Dental Surgery, Beer Hospital, NAM. She's the Founder President of NSPOI and President NADR. And her focus lies with Dr. Kharbanda on dental education and mainly on e-teaching skills. Like we have panelists have suggested, Dr. Kharbanda has also suggested robotic or tele-education or telemedicine, dentistry. So a lot of questions are there. The ball is already set rolling by the presenters. Dr. Derek.
Thank you, Dr. Rajiv, for introducing our panelists. And I think we'll start with Dr. Lakshman, because this is the question on everyone's mind. The media, every day you hear reports of the vaccine, you hear the number being vaccinated, you hear about vaccines being provided all over the world. The students are concerned, the faculty is concerned. Should I take the vaccine or not? How safe is it? Which vaccine to take? And what about the protection? What about the healthcare workers? So if you could just enlighten us on some of these burning issues, Professor Lakshman.
Right. Thank you very much indeed. It's a great pleasure for me to take part in this panel discussion and this meeting. And I also have already sort of responded to one or two questions the meeting participants have raised. Yeah, the vaccines have actually, it's a massive topic. Earlier, when the pandemic started, there were more than 62 companies who were 60 over companies who were producing the vaccines. And now actually a lot of them have, fallen by the wayside. And there are now 20 in the offing going through 3 different phases. So first, second, and third. And so currently we have about 4 to 5 vaccines, which are now available in different parts of the world, starting from mRNA vaccines, which is the Pfizer, BioNTech, and then you have the vaccines from China, the Sinovac, and so on and so forth. And now latest the Johnson & Johnson. So there's a huge array of vaccines, and of course the people are worried about the vaccine efficacy and effectiveness, and also they are worried about the side effects and how long the immunity lasts. Frankly, for some of these questions, like the last one I raised, how long the immunity will last, I saw the one question over there. People really don't know, because we have, this is actually the production of these vaccine over the last 1 year by all these firms is actually a tribute to the human ingenuity in the face of this our adversity. And I think no vaccine has been produced within 1 month, 1 year so far. So it's fantastic. We have these 4 or 5 different vaccines which are now in the offing in different parts of the world. So what you have to realize is that vaccine is, of course, the light at the end of the tunnel, but it is not the just because you take a vaccine, we can't say we are fully protected, because the vaccine protection comes in terms of 2 types of antibodies: neutralizing antibodies and now non-neutralizing antibodies. Just very quickly to tell you that non-neutralizing antibodies are the ones which do not protect you, but it will actually send messages to the immune system to say that, this antigen may arrive later. But the neutralizing antibodies actually immediately can face the antigen, which is the virus. And another thing which is a lot of people actually don't know, or which is not been very common in the literature, the immunity produced by the vaccines are 2 types, right? One is called the sterilizing immunity, and this other one is called the effective immunity. Now, this is very, very important because I don't see this in the literature often discussed, even in CNN and all these other people. So sterilizing immunity is once you get the vaccine, you actually, the virus will not multiply in your system, either in the oral cavity or in other cells, the other cells. So you will be completely neutral, the virus will be completely neutered, and you will not be passing the virus to anybody else, right? Now, the effective immunity is the second thing. So you will be safe from the virus or viral infection, but the virus can multiply in your system and you will be passing the infection to others. So this is where the whole thing actually, to some extent, if you can get 100% sterilizing immunity for any specific vaccine, that will be the ideal vaccine. Now, the question is, now there are 4 or 5 types of vaccine. We don't know which one gives sterilizing immunity and which one gives the effective immunity. So, in fact, people are now, you need large trials, human trials, to find out these various nuances in the vaccine immunity. I don't know whether I'm actually explaining this very well or whether that answers the question. So there are so many different questions which needs to be answered. Yeah. So
Thank you.
Yeah.
Thank you, sir. That was indeed very insightful. And just to summarize and to maybe share my views, I don't consider myself to be an expert on vaccines or the type of vaccines, which one is good or bad or better. But based on the little bit of exposure that I've had, thanks to this bioethics program, we've had a lot of experts coming in, and I've also been fortunate to interact with some of the other people who have been part of the core team on various study panels. And just for the benefit of the students, there are a lot of questions which come in on which vaccine should I take and which vaccine is good and things like that. Most of the vaccination centers at present, at least in India, are not giving you a choice. So I think the consensus is that all the vaccines, whatever are there out in the market, we should accept them as being at least safe. Efficacy and efficiency will come to know down the line. I think we can all understand as health professionals, trying to get everything perfect, literally we do not have the time. So on one hand, we want a vaccine to come into the market early. We want it at an affordable price, and we want to find out its efficacy and efficiency. I think that's asking a little bit too much. So my little bit of advice from what I've gathered, and let me confess, I was also like one of you all, one of the fence-sitters, may I say, initially. But after hearing these people, that we as healthcare professionals need to believe in our fellow professionals who have put out these vaccines. And the statistics internationally also have proven that the vaccine is at least safe. So I myself have taken both doses of the vaccine and there was little or no symptoms, so I can assure you of that much. Again, the question which Professor Lakshmanan has already answered in the chat box, that yes, over 60 is a conscious decision that has been taken. So let our senior citizens get the benefit. And of course, I think all our healthcare professionals who were given adequate opportunity already, you will still be given a chance, I'm sure, if you go to a vaccination center. So with that, let's move on to the questions that come with regard to dental education. So I now request Professor Pratip, who has been a former dean and who has a wonderful oversight, that how can we compensate, sir, for lack of skill development, for lack of clinical exposure, because classes were going on digitally, classes were going on online, and students have learned to learn online to get a lot of information themselves. But what about the lack of skill development? How do they practice that? How do they work on improving their clinical skills? Over to you, sir.
And thank you for letting me sharing with you with some of my experience in this area.
Can you just make it full screen, sir, before we go ahead? Just make the slide show full screen.
And can you see my screen?
We can see your screen, sir. If you can just make it into full screen or screen show.
Okay.
That small icon towards the lower right of your screen, sir, which looks like a screen itself.
And you can hear me? You can hear me also?
We can hear you clearly, sir. Please go ahead.
So may I just present first and then?
Just make it into full screen, sir, please. Screen.
Pradeep.
Okay.
Dr. Pradeep, if you bring your cursor on the bottom of your blue part, there is something called comments, and then from comments onward, when you go right,
your screen.
Pradeep, can you share the screen again?
Yes, I can hear you.
Yeah, Dr. Pradeep, when you first share the screen,
yes,
and when we will see your PowerPoint,
yes,
on the bottom of your slide, on the extreme right hand, if you click that small screen icon, we will see full.
Share like this.
Yeah, now go down on your, just keep this on.
Okay.
And you bring your cursor where it is written 58%. Can you see on the bottom down 58%? Bring your cursor down. Can you move your cursor? Yeah, keep coming down, keep down. No, on your right.
Is that all right?
No. You go to slide number 1 first.
Okay.
Yeah. Then bring your cursor on the main slide screen. Yeah, right. Keep moving on the other side.
Moving right.
Keep moving,
down,
keep moving
down.
further. Keep moving your cursor. Keep bringing it on the bottom.
Down, sir, down and right.
Sorry.
Move the arrow down and right, sir, please.
Is that okay now?
Not yet.
Okay, it's fine, sir. Please go ahead.
It's okay.
Please go ahead, sir.
Understand.
Let me go ahead, okay? Because you can read
it. You can see, but if you bring it full screen, it is still better. But if you cannot, then it is okay.
I think you can go ahead, sir. We can read it. I think because
please go ahead.
We can read it. We can read it.
Go ahead, Pradeep.
Full screen.
Okay. I just go very quick with a few slides only. Okay, with a few PowerPoint only. I think that the dental profession, when we are talking about lack of skill compensation, I think we are thinking of the simulation training, artificial intelligence, which I think Professor Bandara have mentioned already. But I think we should need also something thinking about the non-aerosol procedure. For example, something like the ART, SMART, SMART, or something ART, something that, and then also now you have to know something about the updated caries removal, which is a new area for the restorative dentistry also. And also we have to emphasize more on the promotion and prevention. This is how to compensate for the skill by using some of the other technology like this. Okay. The other one is a lack of the clinical exposure because of we are afraid of the COVID patients. Also we are awareness of the transmission of the COVID patients concern and clinical experience future dentists. I think we have to prepare, as you all know, the PPE and ventilation, airflow, negative pressure. We have to prepare our clinic to suit the situation. And also in some situation, we think you should think of this non-invasive dentistry, which is, I think, in the future we have to be a bit more focused on this one. And as I mentioned again, that in terms of the clinical exposure, if we don't have much enough patients to train, I think we maybe in the future we need to have the internship in dentistry. That means that even though you are when you graduate in dentistry, but you have to work with some experienced dentist for a year or two, similar to the medical profession. And as I mentioned, I think that we in the future maybe we have to think that we are not only the dentist, but we have to transform ourselves to be a future oral physicians or something like that. Which I think there are some questions in the chat box mentioned about the medical and dental profession together. So what is the distance learning? I believe that in the future maybe it might be possible to make a distance learning to develop the clinical skill in the future also. That means we have to develop the simulation and training set, not only to use at the school, but maybe we can try, if they have a simulation training set, we can use at the home use also. And also we can do innovation of the artificial intelligence for clinical for skill training. I think that now there are some, but at the moment it's still too expensive. But I think in the future, if we are working better, it can be make it cheaper. As you all know, now we have the intraoral scanner to replacing the impression taking. I think the orthodontic professor camera and he's using at the moment. So something like this, I think we can use to be in less contact with the patients also, and to develop the CAD/CAM dentistry in the dental education. We all know that now we are using this in the postgraduate, but maybe it's maybe necessary for the undergraduate as well in the future. And also we can develop some using the CCTV to checking the laboratory or clinical practice procedure between the professor and the student, the teacher-student relationship, and through the CCTV for the distance learning, as well as Professor Lakshman mentioned already, the COVID vaccine. So, and the dental profession, as Professor Canberra mentioned, it will never be the same because everything is have to be changed. I think now we are changing, we all know that the orthodontics changing a lot already as to the aligner orthodontics. Instead of using the wires, everything like that is changing. So we are changing the prosthodontic to CAD/CAM and prosthodontic. We can do the immediate implants in right away or something like that. And also now we also have this non-invasive dentistry. We are talking about the selective removal of caries to soft dentine or partial carie removal, which will be leading to no injection, no drill, and no pain dentistry. And also we have to emphasize more on the oral health promotion and disease prevention, because we have to realize that there are many common risk factors between oral disease and non-communicable disease, which is now the World Health Organization try to link up these two altogether, and then working together, so that the oral health is the integral part of the general health, and so that as I mentioned before, that we will become oral physician in the future. We have to have the interprofessional education. We have to study together, and we have to be an active member of the health team, and we have to focus on the health promotion for the life course, and we have a big role in the healthy aging, and also emphasize on oral health self-care, positive, to create the positive attitude of the people toward the dental profession. This is what I think, that this is the dental profession which should be changing or focusing in the future. Thank you.
Thank you, Professor Pratip. If you can just stop your, yes, thank you. You're absolutely right, sir. We have to think of new avenues. We have to use technology. All of us went through that learning curve when we were forced to conduct digital classes, online classes using Zoom. But I think today, if we can all get together, and I can see everyone is so effortless at using this technology, I think we can adapt it to our students and our learning as well. Professor Nilanta, I'll come to you now. Of course, I think the online classes and the digital learning is quite advanced, shall I say, because I think we've all adapted fairly well and our students are happy with technology. But assessment still happens to be a gray area. It happens to be having a lot of challenges, not only for the formative assessment, but summative assessment as well. And these will continue into the future. So what is your insight on the assessment part? What are the challenges, sir, and how can we face these challenges more effectively?
Yeah, thank you so much for inviting me again for this important webinar by UNESCO Chair in Bioethics. Now, I would take this opportunity to thank all the key figures in the UNESCO Chair in Bioethics, Professor Russell, Professor Derek, Dr. Mary, Dr. Rajiv, and especially Professor Karbanda for their all good work. And I congratulate you on issuing this newsletter on dental bioethics. I think fill a lacuna in the field. And my view on these online classes and exams, how applicable they are, will be based on my experience from my field, which is dental public health or community dentistry, and also related to my work background, Sri Lankan context. So basically, I will give you just briefing on the COVID situation in Sri Lanka, because this is directly linked to what I talk about. Since the COVID outbreaks started in March, early March, we got the first case in early March. Then there was a surge towards May and July. And when we did this first webinar on dental lockdown, it was in the peak, like we got 300 cases per day in the first wave. But this first wave eased by the end of July. And there was a period without even a zero case. And we had only very few cases which are overseas acquired. And then again, so this zero case period, that is the end of the first wave, we adapted to the new normal situation, which we call. And during this new normal phase, we slightly came back to our normal routine. But then again, here in Sri Lanka, we started the second wave in the very beginning of October, and still we are in the second wave. And this is the tail of the second wave. Now, these days, again, we get, our peak was, we were getting around 800 to 900 cases per day. Now we are getting average of 300 cases per day. So we are kind of in the tail of the second wave. So now, when this first peak of the first wave came up, all the dental undergraduate and postgraduate training came to a standstill. Then in Sri Lanka, basically we have only one dental school for undergraduate teaching and only one postgraduate institute of medicine where they provide all the dental postgraduate courses. So we never had any online or distant learning courses in Sri Lanka because I mean, geographically, our country is a small one. So, I mean, access to the capital city, I mean, the postgraduate institute is not much difficult. So, all the courses were physical, in-person courses. And also this university, the only dental school, which was in the middle of the country, is, I mean, accessible, and all courses were in person, all teaching were in person. But with this new development, now we were in online courses, particularly during the last 9 months. So we are conducting online lectures in all the fields related to dentistry, and every type of learning is through online. Basically, when I emphasize my field, dental public health, we had to stick to all online assessment tools. And when we go through the literature, what we find is that, I mean, when online teaching is done, the factors that affect these online teaching, what the literature says is skills, then the infrastructure, lack of institutional support, and then the attitude towards this online learning. But what we see is that from our practical experiences, mainly lack of enthusiasm is there among our postgraduate students, particularly when it comes to online things. Now, when I take my specialty, community dentistry, we conduct this master's program in community dentistry, which is a 1-year full-time course, which has a taught course as well as a research. So in my in this course, this research component, now in the beginning of the pandemic, we had to announce the students to refrain from doing any research which involves oral examination, because I mean, oral examination, particularly in the field setting, is not allowed by the Ministry of Health. So all the mobile programs were stopped, so as all the research in the field. So it is a massive blow to those postgraduate students who do dental public health. And then what happened to the doctorate MD trainees? They have done most of these studies halfway. They have collected data halfway, and their training is dragging on. I mean, they have a minimum period to submit their thesis. Now they have problems. Then for the master's program, of course, we had to give an option. Those who have not completed their data collection in the field, I mean, they can't complete their dissertations. So in that case, our institute, the PGIM, Postgraduate Institute of Medicine, they gave a data set for the students to analyze it and answer some questions given by us. So we had to switch to another option rather than giving a dissertation on research. And for the latest batch, recently we started this MSc course for this year. Now, for the past 2 months, they have been in front of the screen from 8 to 4, studying dental public health in front of a computer screen. So, I mean, literature says that this online teaching is successful. I mean, I found a meta-analysis and systematic review, which says that out of 16 studies they have studied, 6 says online teaching is significantly better than in-person teaching. Whereas only one study says that in-person teaching is better than online teaching, and rest, the nine of the rest studies showed no difference, significantly no difference. But this is the literature. But actually, what we feel is that there are several things, several drawbacks in this setup. I mean, last week I happened to sit in a small group discussion. It's online, virtual, where we discussed the research projects of students, and I mean, none of the students were keen to switch on their videos. So, what is the ethical aspect of that? Can the trainer ask the students to switch on the cameras? Then again a dilemma. And I mean, we should address all these things when it comes to teaching. And evaluation, of course, will be a massive problem, because our students can't do their thesis and dissertations, particularly in the field of dental public health. So, I mean, basically clinical things were discussed. This is the aspect of dental public health that we face. So we have to discuss.
Yes, sir. Thank you. I think you're echoing all our thoughts as well. And in the same line, let me now invite Professor Shaili Pradhan from Nepal. I'm sure, ma'am, that you also must be having a lot of shared experiences. Again, may I ask you to focus on the online assessment as well as the challenges in clinical education? Because I think we know the problems, we've understood the challenges quite well by now. So if you could just highlight for us, what are your take on assessment, and how do we keep the clinical skills part? How we address that issue? If you can, yeah.
Thank you, Dr. Derek, and namaste to all of the distinguished members out here. Thank you again for giving me the opportunity to participate in this great event. Actually, my topic was on e-teaching skills, so I had prepared more on that. But however, we can still discuss on the assessment part also. Just to briefly talk about what I have prepared. I think Kharbanda sir has given a very good background regarding the dental education, very in short, but he has covered almost every aspect of the dental education. Now, dentistry, we have got, it's the amalgamation of theory, practice, as well as the laboratory work also. So for theory, we need e-teaching skills. I'm also still learning this e-teaching skill. This COVID has brought a real challenge in this academic dental education and academics of the dentistry, including taking theory classes, including taking, as Dr. Nilant has spoken. Sorry. As Dr. Nilant has spoken about the assessment. Now, this e-teaching skill, it has got both advantages as well as the barriers or the difficulties or the challenges. Advantages is like in this, with this e-teaching skill only, now all of us are gathered here in one platform, from USA to Australia, Sri Lanka, all the participants are here. We can discuss in spite of like it's morning in the USA, it's evening, it's night at Australia, it's evening here. We can gather and discuss. So this is the advantage of the e-teaching skill. However, it has got lots of disadvantages, like lack of IT skill. Okay, so when it came, the COVID came as a challenge, and everything came to standstill. This really brought a big challenge to those teachers who lacked how to use this technology. But slowly we are learning, and we can see that we are becoming so friendly in using these e-teaching skills. And another disadvantage of e-teaching skill is it is monodirectional. I mean, we cannot interact. Usually teaching learning it has to be interactive, but here it becomes so much monodirectional that we cannot really interact with the students. So we do not know, as already notified, we do not know whether we should ask our students to put on the camera or not. For that, we have to develop some online ethic, like put your name, don't switch off videos, and come 5 minutes before, like that. We can develop some online ethic for the e-teaching skills. And then, and also this e-teaching skill, it may be good for theory, but as already mentioned by Karmanda sir, it is very difficult for the clinical practice. It has to be virtual patients, virtual technology will not work on dentistry. It has to be real-time patients. So it becomes very difficult. Just giving theory is not enough for in the dentistry. It has to be clinically oriented also. So it's a real challenge in the medical education world. Now, I think we have to give this training to the faculties, to the teachers, how to take good online classes, because just delivering is not, we are not done just delivering what we want to deliver. We should know whether the learner has taken the thing or not also. So we have to develop some e-teaching skill online, maybe some online training. We have to incorporate this portion in the teachers training also. So it's a really big challenge. So regarding assessment, I also don't know, like it's a really challenging to give online, to take online assessments, this online, how to take the online assessment, it's a big challenge. I think even I have to learn how to assess a student, whether he has learned or not, whether he passed or failed. I mean, it becomes really difficult. We don't know whether the student has copied from somewhere else and given us the written answer. So it's a really this thing, but it has to be hybrid. Dentistry has to be hybrid. Online, more than online assessment, I think it has to be physical, with the reduced number, with the social distancing, with the all those safety measures. We can do the assessment part, has to be one-to-one, or what we had been doing. In my personal view, only online assessment we cannot assess. That means we will, if we do only online assessment and produce the dentist, it may be harmful for our own patients. So assessment has to be like, in a reduced number, in the physically, it has to be, in my personal view. So this e-teaching skill has to be learned by every faculty. This is a new thing that has come up in the dentistry. So it has to be learned by all the faculties, how to give our, what we want to deliver to the students. I think I will add on later on, because many things have been covered by all the prior speakers. Thank you.
Thank you, ma'am. Dr. Rajiv, I believe you had a comment or a question for Dr. Shelley.
I had some questions for Dr. Shelley. Students have been very active. I want to congratulate all the students who have been actively pursuing bioethics, and they have been actively asking all the questions on the chat, and all our experts have already been answering them. I had some questions, but ma'am has already answered. There are some pertinent queries or questions which I can take the opportunity to, Dr. Shes, has put up a question that are we prepared to handle round two? Like, when India, when we were having 5,000 to 10,000 daily in a city, and so all the clinics were shut. So suppose we reach a round two with so many patients a day, what different is it going to be for a dental practitioner? Or are the institutes going to be closed again? Particularly if Dr. Peter Mosey and Dr. Chad Ghani could, give their views on this. Are we prepared for round two?
I think we already went through round two in United States, and we are well prepared. We look at the evidence. We do not go after hypothesis. We go after the evidence. What does the evidence dictate? And according to the evidence, we have to take proper precautions. Again, there is a false sense of security amongst many of us. Oh, I had my COVID vaccine number 1 and 2, so now I'm immune, so I will not be passing on COVID to other people. Of course, that's a wrong decision and wrong thought process in somebody's mind. Social distancing, double masking, washing your hands, and using universal precautions. In United States, the health department will knock on my door unannounced, and they will actually come and inspect my office at any odd hour, looking for the documentation and looking for the evidence. Is this dental office actually properly social distancing within their office? We have no magazines in our office anymore. If I give a pencil or pen to a patient, I do not take it back from him. It's for them to keep it, or we go paperless. And also, any high touch areas have to be again disinfected with proper disinfections. If you do all those precautions, we are pretty much ready to go through second, third, and hopefully it won't happen, but we are ready. And I want to tell the dental students, and I saw there were about 330 dental students at one time. I want to tell them that they are in the best profession in the world. Dentistry is very resilient. Dr. Kharbanda showed the foot engine that I used to keep it in Wadala, Mumbai when I was a dental student. And then my brother trashed it away. I wish I had it. I was trained on that foot engine.
I
And
keep
from
it
that
with
foot
me,
engine,
Dr. Gahani, it is in my office still. I
yeah,
preserved it.
my brother just threw it away after I immigrated to United States in 70s. He just found no use for that stainless steel thing. He just threw it away. The bottom line here is the dentistry has always evolved. I remember being a dental student at Columbia University where I did root canals with bare hands. And if the patient with hepatitis came in, we used to take the cover. We used to hide that I don't want to treat a patient with jaundice. That is now past. So we will evolve, and we are pretty well prepared. And dental students, you're in the best field in the world. I know you're looking for how is your future. Your future is bright, and you will make tons of money. And I'm going to stop there.
Thank you. Thank you for telling us that and for encouraging the students. So you're absolutely right. I think each and every one of us here have gone through those times. I remember when bloodborne infections was the high on everybody's mind. And again, the questions were, will it affect dentistry? Because like you said, a lot of us went through that phase where we practiced literally with bare hands. And God has been kind, shall I say, but we've lived through that, we've worked through that, and I'm sure that we'll see a wonderful future. Let me get Dr. Peter Mulvey's comments on everything we've discussed, sir, and what you feel is the future and some focus areas where we as faculty, may I say, need to develop things so that the students will benefit.
Dr. Peter. Thank you very much. And just to add one little bit of additional evidence to what Chad has said to enable us to have confidence in our profession to be resilient and to adapt. An ADA survey, which was carried out because of the assumption that dentistry was a high-risk profession, showed that in fact dentistry is one of the lowest risk professions. And again, that is because we are so used to adapting to the precautions that are related to infection. So we did exactly the same now with the airborne infections, and we have discovered that dentistry has been very successful in providing a safe environment for dentists and for patients. So, and again, that's just to add a little bit of evidence base. Now, in terms of the future, the resilience that we have shown is not only as dentists, but also as public health professionals. At least here in the UK, because of the focus over the last 6 or 8 weeks on the prioritization of vaccination, our hospital did another lockdown except for emergency dental procedures. And all of our NHS and some of our academic dentists instead trained to be vaccinators and have been doing that over the last 8 or 10 weeks. That's a tremendous public health gesture. But in actual fact, what dentists should be is public health professionals. We should be regarded as professionals beyond the practice of dentistry in terms of general health. And in the future, I would hope that that will be one of the outcomes of this. For example, we have unique access to the healthy population. Patients tend to go to their medical practitioners or to hospitals when they're ill. We see patients when they're well. We should be preparing ourselves to be much more in line with other public health professionals in monitoring blood pressure, monitoring blood sugars, monitoring cholesterol, doing aspects of smoking cessation and dietary advice that provide us, when we have the skills to do it, to be able to provide a service. And that aligns very nicely with the WHO Executive Board resolutions 2 months ago, where we are now a trusted partner in the Non-Communicable Diseases Alliance. Both the IADR, International Association of Dental Research, and the FDI, International Dental Federation, are partners in the Non-Communicable Disease Alliance, and obviously along with WHO. So those three major organizing bodies that we are part of are now encouraging us to adapt and to make sure that we are part of that public health effort in the future. And when Chad has just said our future is bright, with these kind of adaptations and resilience, our future is indeed very bright. And I can assure all young dental trainees and students that we do have a tremendous role to play in the future in public health.
Thank you, Professor Peter. And on that hopeful note, it gives me great pleasure to now invite Professor O.P. Kharbanda, who literally sets the ball rolling for us and who has been keenly following the complete discussion, hearing all our wonderful panelists from all around the globe giving their opinions. So your final closing words and summary, sir, of what we've discussed, the way forward, and how we would like our students and faculty to adapt to these new challenges. Professor O.P.
Thank you. Thank you for this opportunity. I would be brief, but I would be very pointy. And the first and the foremost thing which I think COVID-19 has told us, that what we are doing now, for example, in terms of practice, in terms of aerosol management, we should be even doing it even before COVID. And even when COVID is gone, we should continue with this because we have learned, which we did not know before. COVID has made us see that yes, saliva has droplets which is spread in the aerosol. And we are generating that without knowing it. So these are dental surgery fumes, I would call it. Dental surgery fumes, which need to be tackled. And of course, we have to continue with all other precautions. And number 2 point, which emerges out of this is that a lot of emphasis, because there is a question even in the chat box, people are asking, and I told them, we are not just dentists. We are healthcare workers. The integration with medicine is a must. We were part of medicine, but slowly we drifted away. But time has come, this integration is required. If we as a dentist posted in a primary health center am not able to visualize a hypertensive patient, a patient who is susceptible to a stroke, a person who is becoming more diabetic, then I'm failing my duty as a healthcare worker. So as a healthcare worker, our curriculum needs to be integrated more with medicine and practical medicine. Practical medicine. We should be prepared for screening sort of thing, what Peter has already said. With respect to COVID, the curriculum now, it requires training of both the students and teacher, and that phobia of using new technology should go away. That means one very good point which Shelley has raised, I must admire her, that there is a need for code of ethics for e-learning. For example, if we ask a student to switch on the video, we don't know if she wants or not, but if the code of ethics is there, if we know that the person is logged in with their own name and what environment they are sitting, if environment is not connected to each other, only talking will not do. So for a better communication and better learning to take place, the environment integration is also required between student and the teacher's environment. And I think, and for that we need a code of ethics. And I think the UNESCO chair can think about it, making a small group who would develop this code of ethics on e-learning or e-communication. Pradeep's point I liked something very nice was artificial intelligence. AI is coming in a big way. And the second aspect which Pradeep always emphasizes is atraumatic techniques. I think we have to learn how to be less traumatic, less invasive in dental procedures. That should be there. Chad has very nicely emphasized that the challenges need to be faced with evidence. And when there was evidence that we will be harmed, he took a decision to close the clinics. In United States of America, and many other countries followed suit. So we should follow the evidence, and of course, the cost of treatment is going to be high if we have to take care of all the precautions. Dr. Lakshman, thank you for giving us insight into the types of immunity we develop and giving us confidence to have the vaccination. I could see your comments in the chat box also. And Dr. Lakshman, thank you for your experience with evidence as well as your own experience in e-learning and e-teaching in Sri Lanka. I think I have covered most of it. And if I have to say, in summary, what is the way forward? The way forward is to change, because change is the only constant in life, I think. So we are constantly changing. We are constantly adapting to the new situations, and we have adapted. I remember extractions being done with bare hands, and one of our faculty colleague developed hepatitis B, and after that they were made compulsory. I'm talking about 1971, 72. So things like that, we evolve, we learn with time. And if we have been able to face challenges, I remember those days, some people used to write AIDS-free clinic. So do we have a COVID-free clinic? I don't know. So there has to be some guidelines on that. Should come up at some stage, and the dentistry has a future for certain, and we will overcome that as well. And I think with this note, I will stop here and take over Dr. Derek or Rajiv.
Dr. Derek, if I may, coming from the point of Dr. Kharbanda, COVID-free clinic, one of the questions is also there that how can how should a patient coming into a clinic, can he realize the claim that this clinic is COVID-free? Everybody is saying we are vaccinated and we are doing all this. Is there a marker a patient, or what needs to be done for us to claim that we are a COVID-free environment, workplace? Anybody?
Excellent point, Dr. Rajiv. And I think if we consider ourselves to be health professionals, then I don't think we need a marker or we need a certificate from someone. I think it's high time each one of us stood up to be counted as a health professional, to ensure that the standards that we maintain in our clinic, in our practice, in the way that we practice the profession, we ensure it is safe not only for us, it is safe for our health team. It's important we consider their safety as well. We ensure that they come in to the dental clinics, they come into the dental office and ensure that they will not carry something home. Their families are safe. And their practices, I think as leaders, this is an area we need to consider. And again, the patients will automatically have confidence in us if we know that we are doing the right thing. If you do the right thing, if your practices are in place, if your SOPs are there, that itself will bring you the confidence. You will feel a sense of belonging. You will feel, we all spoke about public health, we all spoke about responsibility to our clientele. And that will only come if we have our practices in place. And I'm glad that all our panelists highlighted the important areas. I know we couldn't go into a detailed discussion, but possibly we'll have a whole day conference, Dr. Rajiv. I think we can plan for that in the future, so we can come out with very focused guidelines for the faculty, for the students, for the dental team. So let's work on that. Let's just look at this as a beginning. We have all the student questions. Thank you so much, dear students, for giving us those questions. Let me tell you that even though some of them may not have been answered directly, I know that the panelists have covered most of the important areas. We've made a note of the gray areas that still exist, and we'll take that up in the future. So on that note, may I request the head of the UNESCO Bioethics India program and someone who's been here literally throughout all the 37 webinars that are there. We've given her a chance to rest, otherwise she's been the lead moderator for us, and yet she's stayed on. Professor Mary Matthew, thank you so much for your contribution. And it gives me great pleasure to invite you to thank all our panelists and to summarize the evening for us.
Thank you, Dr. Derek. It's been wonderful listening to all of you. I was reminded of the fact when Professor Chad and Professor Karbanda talked about using their bare hands, and the patient had hepatitis. I remember when we were interns, we had to deliver babies with our bare hands because babies never told us when, they never timed their delivery, and often we would rush with bare hands. Even before we had time to put on the gloves, the baby would be out. And in one such case, the mother was syphilis positive. So I can empathize with what all of you are saying. And I think it's lovely to see that there is hope, because the students are quite worried about what is going to happen to their future. And this panel has given them the hope that this profession will continue, that it's not going to collapse. We are going to change and we're going to adapt. And that is what Professor Karbanda said, change is inevitable. We have to change with the situation. So I want to tell you that we had at least more than 300 participants in today's webinar. And it's really nice to see the student participation. And I thank all the speakers today, Professor Chad, Professor Karbanda, Professor Peter Mose, and all our panelists also, Professor Lakshman, Professor Nilanta, Professor Pradeep, and Professor Professor, is it Shali? Okay, right. The spelling was different, yeah. So Shali, because this is an education platform, and it's lovely to see that we are learning from this. And let me assure you, Professor Karbanda, we have used this platform to bring out white papers and guidelines, and we have done that for the nursing faculty. We have done it we're doing it for the physiotherapy, and it's high time we did for dentistry. So I'm sure Dr. Derek and Dr. Rajiv and Dr. Russell also encourages that we will get together a team that could bring forth guidelines, especially what you talked about, that is the code of ethics in e-learning in dentistry. That would be very good. We shouldn't wait for the next pandemic to happen to think about these kind of things. This is the time, and we should capitalize on all these, on what we are doing. So thank you very much to all our panelists and all our speakers, to Dr. Derek and Dr. Rajiv. Wonderful job in moderating the sessions and also the release of Ethoscope. Students are our future, and they will drive it and take it forward. So I thank all of you. And on behalf of Professor Russell, and of course, Professor Kami also has stayed on So I thank you on behalf of the UNESCO Chair in Bioethics, Haifa, for taking part in this webinar and making it such very, really a success. Thank you very much.
Thank you.
Thank you, Dr. Mary Matthew. And thank you, Professor Kami. To see you here for almost 2 hours itself is heartening, and it shows us the importance that you place on behalf of the UNESCO chair. And we are glad to follow in your guidance, and we look forward to your guidance in future. Very encouraging for you to be here with us. And thank you once again to all the panelists, to each and every student, to each and every one who has contributed, and we'll take this forward in the days to come. Professor Russell was having data issues because he's away from Melbourne. He's a little bit into the hills, so connectivity has been an issue. He's been messaging me. He's been following everything that has been going on, but he's unable to be with us to the end. So thank you once again, and it's really been enlightening. There's a lot of work for us to be done, and I'm sure Dr. Rajiv and Professor Opi, as they have put all this together, will take us forward into the next step, because it's a continuous process. And thank you once again, each and every one of you, for showing solidarity, for guiding us together as we work to this common goal of a better and brighter future for everyone.
One thing
on that happy note, thank you everyone. Have a wonderful evening and best wishes.
So, sir, can I just one second? I just want to request everyone to thank everyone for the contributions and guidance for the Ethoscope, and I request that everybody can write their questions, doubts, or the experts and even panelists their views, and we'll be carrying it in our next issue. So, and my email ID is in the mails in which I've addressed all the panelists and presenters and experts. And because while doing the newsletter, I've realized that it has really percolated down to the students and into the interiors. So I feel it's a wonderful, gadget to take up the cause of bioethics. And also I thank Professor Kami, for being online for this. This is my first interaction with you. So thank you so much. And for igniting bioethics with us. Thank you, thank you everybody, especially Dr. Souza, Mary ma'am, who's I can call her any time, and she's always so helpful. And Dr. Derek is my friend. I take it for granted that he'll always be there. And thank you so much, everyone.
Thank you, everyone.
Thank you.
Good night. Till we meet again. Bye-bye.
And bye.
Lakshman, thank you, Peter.
Thank you.
And thank you, everybody.
Thank you, everybody. Thank you.
Bye-bye.
Thank you, Rajiv.